Good afternoon, everyone. My name is Omar Aboshady. I'm a third-year PhD student at the Department of Pharmacy Practice at Purdue University College of Pharmacy. It's my great pleasure to present today the work we have been doing over the last 2 years to understand the cardiac repolarization change during pregnancy with a specific focus on the sex hormone. So, as you know, cardiac repolarization is an important clinical and drug safety biomarker for arrhythmia, and it represents the process by which ventricular muscle regain their ability to depolarize again. And it's measured in the ECG by what's called QT interval. You can find it here. It is from the beginning of the QRS to the end of T wave. And the QT interval is known to be affected by heart rate. Faster heart rate leads to shorter QT interval. That's why there's multiple formulas such as Bazet or Framingham that account for this effect of heart rate. The normal heart rate corrected QT, or what's called QTC interval, in non-pregnant adult female is between 360 to 460, which is higher than the male by 10, the adult male by 10 milliseconds. And this difference is mainly attributed to the sex hormone because the sex hormone are known to affect ion channel in the heart. The QTC interval prolongation more than 500 milliseconds is associated with 2 to 3-fold increase in the risk of torsades, which is catastrophic clinical event which usually lead to sudden cardiac death. As I mentioned, that sex hormone affect ion channel and specifically voltage-gated potassium channel and voltage-gated calcium channel. So estrogen are known from patch clamping study and also clinical study that it prolongs QTC interval by enhancing the L-type calcium channel and inhibiting IKR. In contrast, progesterone shortens QTC interval by inhibiting L-type calcium channel and enhancing IKS, potassium channel IKS. And we also know that estrogen and progesterone increase 10 to 20 times as before pregnancy, as you can see here. In the x-axis, there's time in pregnancy in week. In y-axis, you can see the estrogen and progesterone and their metabolite level. And you can see here, starting from the second trimester, both estrogen and progesterone go up very fast. However, the rate of estradiol is higher during the second trimester, while the rate of progesterone is higher during the third trimester. So not only sex hormones that may impact cardiac repolarization during pregnancy, but also there is additional cardiac change that happen during pregnancy that may affect cardiac repolarization, such as ventricular hypertrophy. So in this picture, this is the non-pregnant ventricles. During the normal pregnancy, the chambers increase in width, and also the thickening of the ventricular wall also increase. And also, in preeclampsia, there is additional increase in the thickening of the ventricular, what's called concentric hypertrophy, and this usually is permanent and usually remain after delivery. Also, in preeclampsia, there is increase in sympathetic outflow and some electrolyte disturbances, such as hypocalcemia, that are known to affect the cardiac repolarization. So not only these physiological changes that may impact cardiac repolarization, but also there is multiple QT prolonging drugs are commonly used in pregnancy, such as ondansetron and SSRI, with prevalence about 3 to 5%. So all these changes are expected to affect the cardiac repolarization during pregnancy. But this raises two questions. The first one, what is the status actually in the literature about QTC interval during pregnancy, and if there is a relationship between the hormonal fluctuation and QTC interval? And we found a significant gap. That's why we try to fill by answering these two questions. The first study we did is a systematic review and meta-analysis that aimed to quantify the changes in QTC interval across pregnancy trimester with and without preeclampsia. And second study, which is ongoing now, it's a clinical cohort study where we aim to assess the relationship between the changes in sex hormone level and changes in QTC interval during pregnancy. Due to the sake of the time, I will only present the main result from our study one, which is a systematic review. It just published in Clinical Pharmacology and Therapeutic. You can read more about our methodology and also our main results. So we conducted a comprehensive search in 8 medical databases from their inception to January 2025. We added any study design except case report and series, and the study should report QT and heart rate or RR interval and or QTC interval for at least 1 trimester during pregnancy. If the study reported at least 2 trimesters or 1 trimester and non-pregnant control, we did meta-analysis to calculate the mean difference between the group. In this figure, it's showing a box plot for different 5 groups. The first group is non-pregnant control group, first trimester and second trimester, third trimester normal pregnancy, and third trimester preeclampsia. On the y-axis, you can find the mean QTC corrected by Bazet in millisecond in 40 studies. As you can see here, the median of the mean QTC is increasing during the first and second trimester and slightly went down during the third trimester normal pregnancy. However, the maximum increase happened during the third trimester preeclampsia. To see if this increase is statistically significant, we found 33 studies reported at least 2 trimesters, and we were able to capture the mean difference across the different trimesters and non-pregnant control. So compared to non-pregnant individuals, the first trimester increased QTC by 10 milliseconds in normal pregnancy, while the second and third trimester increased the QTC by about 20 milliseconds. Additionally, preeclampsia added additional 20 millisecond increase compared to third trimester normal pregnancy. So overall, there is a significant increase in the QTC interval across the trimester, reaching the maximum in the third trimester preeclampsia. So as I mentioned in the background, the hormone is known to increase during the second and third trimester, and also we found increase in the second and third trimester in the QTC. The question now is there is a relationship. That is our aim for the study 2, which is BreakCard clinical cohort study. It's still ongoing. I will present the protocol and some of the demographics of already recruited patients. So in this study, we are aiming to recruit healthy pregnant women. Their age should be above 18 years old, and the gestational age at the time of recruitment should be between 18 to 22 gestational week. If the woman has any known or suspected fetal abnormalities during the current pregnancy, or any family history of long QT syndrome with Torsades or sudden cardiac death, or taking any hormonal QT prolonging drug with known risk to induce Torsades, they will be excluded from our study. Here is the study procedures. It's a 3-visit study. The first visit, as I mentioned, between 18 to 22 during the second trimester. The second visit is early third trimester, 28 to 32 weeks, and the third trimester, late third trimester, third visit in the late third trimester, more than 36 week. At each visit, we will conduct 3 12-lead EKG, and we will measure the serum sex hormone and metabolite. This will be repeated in the other 2 study visits. Additionally, during the first visit, we will do genotyping to assess the polymorphism in the SEP involved in the metabolism of sex hormone to see if there's a relationship also with the metabolites. So currently, we recruited 37 patients. We have just 3 more patients to finish the study. Out of the 37, 23 already completed their visit, and still 11 patients ongoing. In this table, you can see the demographic data for the 34 patient. The median was about 26 years old. They has been most of them get pregnant before, and most of them are non-Hispanic, and we have a balance between white and black in our study. So to conclude, our systematic review found significant QTC lengthening throughout trimesters of pregnancy compared to non-pregnant women, with additional increase in preeclampsia. Our BreakCard study hopefully will provide insight into the relationship between the sex hormone and metabolite fluctuation and QTC interval during pregnancy. At the end, I wanted to acknowledge all my mentors, my colleagues at the Ops and Gynae, and also our Purdue grad students. And this work has been supported by mBrand Opportunity Fund Award. Thanks so much, and I'm looking for any questions.